Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues in PGs, in the second part of our discussion on portal hypertension, we shall discuss the role of beta blockers in treating portal hypertension cases. We shall find out the targets or the ways how we can decrease the portal hypertension by using beta blockers. So in this part, we are discussing the role of beta blockers in portal hypertension. We discussed this slide in the first part, and I told that there is paradox in the nitric oxide concentration on the splanchnic circulation and on the intrahepatic circulation. On the splanchnic circulation, there is increase in the concentration of nitric oxide, which leads to the vasodilation, and because of this vasodilatation, there is increase in the blood flow into the portal vein. And we know that when the blood flow to the portal vein is increased, it will lead to the rise in the portal pressure. While on the other hand, in the intrahepatic circulation, there is decrease in the nitric oxide concentration, and because of this, the vasculature at the sinusoidal level, they go into a spasm and offering resistance to the portal flow. So the portal hypertension, which is found in the cirrhotic patient, is because of two reasons. Number one, the vasodilatation, which leads to the increased blood flow in the portal vein. So the blood flow in the portal vein is increased. And on the other hand, there's increased resistance to this portal flow at the sinusoidal level. And this resistance is because of two components. One is because of the collagen deposition and fibrous tissue deposition, which is the fixed one, which is irreversible one. And the second component of this hepatic resistance to the portal flow is the sinusoidal vasoconstriction. And to lower down the portal pressure, we need to decrease the portal flow by decreasing the amount of blood coming into the portal vein, as well as we need to decrease the resistance offered to this portal flow in the hepatic level. We cannot decrease the resistance which has been offered by the fibrous tissue, but we can decrease the resistance, which is a reversible one, or which is because of the vasoconstriction. So these are the two targets by decreasing portal inflow, and second by decreasing the intrahepatic resistance because of the which is being offered because of the vasoconstriction. So to further elaborate on it, this is the portal hypertension, and the reason is I told you is one is because of the increased portal venous blood flow, and the second is this is because of the increased intrahepatic resistance, and this is one is the architectural, which is around 60 to 70%, and second is the dynamic, which is because of the vasoconstriction, and this makes the 30 to 40% of the increased intrahepatic resistance. So these are the two basic components, that the portal hypertension is one because of the resistance increased, and second because of the increased portal venous blood flow. Because of the splanchnic vasodilatation, which I just told you, because of the increased concentration of the nitric oxide, there is also a decrease in the it leads to the hypotension in the effective volume, and this leads to the neurohumoral activation and vasoconstriction, which leads through the sodium and water retention, leading to increased volume by the kidney, and this again increases the venous return to the heart, and it again leads to the increase in the cardiac output. So the nitric oxide concentration increase on the splanchnic circulation, what it does, on one hand, it increases the blood flow directly, and second, through this mechanism, the hypertension in the effector volume, leading to neurohumoral activation and vasoconstriction, leading to sodium and water retention by the kidney, and increased venous return to the heart. So these are the two ways how the nitric oxide concentration leads to the increased portal venous inflow, and thus increasing the portal hypertension. Now, we know there are two beta blockers with us. One is propranolol, another is carvedilol. Propranolol is the non-selective beta receptor blocker, while the carvedilol is a weak alpha receptor blocker as well as a potent non-selective beta blocker. So the difference between these two is that propranolol acts only on the beta receptors and blocks beta receptors, while the carvedilol, it blocks beta receptors, beta 1, beta 2, just like propranolol, but additionally it also blocks alpha 1 receptors. Let's further see these in details. The receptors, they are alpha receptors and beta receptors. Alpha 1 and alpha 2, and beta receptors are beta 1, beta 2. The alpha 1 and alpha 2 receptors, they are distributed in the systemic and splanchnic blood vessels, and when they are stimulated, they leads to vasoconstriction. The beta 1 receptors, they are distributed on the myocardium, on the cardiac muscle, and when they are stimulated, they lead to increased cardiac heart rate and increased contractility of the left ventricle, leading to increased cardiac output, both the right and the left. So the stimulation of the beta 1 receptors will lead to increased cardiac output because of the increase in the heart rate and increase in the contraction of the myocardium. The beta 2 receptors, they are distributed on the splanchnic blood vessels, and when they are stimulated, they lead to vasodilatation. So this is what we know are basic pathophysiology. So what is the consequences of these if we block these? When we block beta alpha 1 or alpha 2 receptors, what they will lead to the vasodilatation, because now the vasoconstriction has been masked and there will be resultant vasodilatation. By blocking the beta 1 receptors, it will lead to decrease in the cardiac output because the heart rate will be decreased as well as the contractility of the myocardium will be decreased. And by decreasing the beta 2 receptors, that will lead to the vasoconstriction in the splanchnic blood vessels. So this is the way when we use the propranolol or carvedilol, what does they do? So when we give a patient a propranolol, which is the non-selective beta 1, beta 2 receptors, what it will lead? It will lead to decrease in the cardiac output. So there will be the blood flow into the portal vein will be decreased, as well as by blocking the beta 2 receptors, it will lead the vasoconstriction into the splanchnic circulation, and because of that, the blood will be redistributed. It will be pushed from the splanchnic blood vessels to the systemic blood vessels. So again, the propranolol, it decreases the amount of the blood within the portal vein, and with this mechanism, it lowers down the portal hypertension. What does the carvedilol do? Just like propranolol, it decreases the blood volume in the portal vein because of the beta 1, beta 2 receptors blockade. But additionally, as I said, it has got alpha 1 receptor blocking activity as well. And because of this, the vessels which are present in the liver, they are vasodilate, they dilates. It results in the vasodilatation of the intrahepatic the vasculature at the sinusoidal level. So what I was telling you, that the resistance, which was having two components, the fixed 60 to 70% because of the fibrous tissue, which is irreversible, and 30 to 40% resistance, which is because of the vasoconstriction, because of the decreased concentration of the nitric oxide. When we give carvedilol, those alpha 1 receptor carrying vessels, they dilates, and when they dilates, the resistance offered to the portal flow, it is lowered down. So by giving the propranolol, we decrease the portal pressure by decreasing the volume of the blood in the portal vein. While by giving the carvedilol, what we do, we lower down the volume of the blood in the portal vein and in the portal system, as well as we lower down the resistance offered to this portal flow at the sinusoidal level in the liver. So the both the components which results in the portal hypertension, they are effectively affected and the portal pressure goes down. So this is just to explain what I told you, that the increased intrahepatic resistance and the increased portal venous flow. So by the carvedilol as well as the non-selective beta blocker, that is the propranolol, by decreasing the beta-1 adrenergic activity, the cardiac output will be low, and at this through beta-2 receptor blockade, again the blood flow in the portal vein will be low. So this is where the carvedilol and propranolol, they have the same effects. But the additional effect, what I told you of carvedilol, is that it affects on the dynamic components of the increased intrahepatic resistance. This is 30 to 40%. And because of this increased additional effect, the portal hypertension is lowered down more effectively as compared to the propranolol. So the non-selective beta blocker, either the propranolol or the carvedilol, they decrease the portal pressure by approximately 15%, and this is because of the blood volume in the portal vein is decreased. Carvedilol has an intrinsic alpha-1 receptor blocking effect, which causes intrahepatic vasodilatation and further decrease portal pressure. At the low doses, this is a good point, at the low doses of carvedilol, that is 6.25 to 12.5 milligram, it does not cause hypertension, but it decreases portal pressure significantly more than propranolol. And this is the edge of the carvedilol on the propranolol. So carvedilol is a much more potent non-selective beta blocker because it has an additional alpha-adrenergic blocking effect as well. Clinical benefit from non-selective beta blocker stems from a significant reduction in the portal pressure gradient, which is determined clinically as a hepatic venous characterization of the hepatic portal venous pressure gradient. To prevent first variceal bleeding or liver decompensation, the HVPG must decrease by below 12 millimeter or at least 10% of the baseline, preferably by at least 20%. And this is achieved in about 50% of patients receiving propranolol and in 75% of patients when using carvedilol, even in propranolol non-responders. The satisfactory response to non-selective beta blockers are associated with a decreased risk of bleeding as well as a lower risk of ascites, SBP, hepatorenal syndrome, and a better survival rate. This is the total evidence of the beta blockers in the portal hypertension. For the pre-primary prophylaxis, more than one randomized control trial, they failed to show prevention of the large varices and more adverse events. So the beta blockers are not indicated to prevent varices or progression. So this is what the data is there. In the prevention of the decompensation, there is one randomized control trial in the compensated patients with clinically significant portal hypertension, and it has shown that they are indicated to prevent the decompensation. Prevention of the first variceal bleeding, various randomized control meta-analysis have shown that they decrease the bleeding, improves the survival in the compensated and high-risk varices as well as the decompensated and high-risk varices. So both grade 1 and level 1 evidence is there. So they are indicated in the prevention of the first variceal bleed. The prevention of the variceal rebleeding, various randomized control trials, the meta-analysis, they have shown that it decreases bleeding, rebleeding chance, improves the survival rate. So again, it is indicated. In the gastric varices, that is the prevention of the first bleeding, GOV1 or 2 or intra-gastric varices 1, the prevention of rebleeding is better with the cyanoacrylate and it's superior. So there is no strong evidence of using beta blockers in prevention of the first bleeding of the GOV1 or 2 or intragastric varices 1. The portal hypertensive gastropathy, one randomized controlled trial did show that it decreases rebleeding. So it's a grade 1, level 1B, and it is indicated. So if I summarize the use of beta blockers, they are not indicated in prevention of the pre-primary prophylaxis, as well as there is no strong evidence to recommend them in the gastric variceal bleeding, primary prophylaxis of the gastric variceal bleeding, but they are indicated in prevention of the decompensation, in prevention of the first variceal bleeding, that is the primary prophylaxis of the variceal bleeding, as well as in prevention of the variceal rebleeding, that is the secondary prophylaxis of the variceal bleeding, as well as in the portal hypertensive gastropathy. This is a summary of the different trials which are available for the use of beta blockers in the portal hypertension. I would like to share one study with you, which is the beta blockers to prevent decompensation of cirrhosis in patients with clinically significant portal hypertension. These were the patients with clinically significant portal hypertension, and I told you what is the clinically significant portal hypertension in the first part of this, and it was a randomized, double-blind, placebo-controlled, multi-center trial. And in this trial, which was multi-center, double-blind, randomized control, the long-term treatment of patients with compensated cirrhosis and clinically significant portal hypertension with non-selective beta blockers was whether they can prevent the progression to clinical decompensation or death. This is the first randomized controlled trial to show that long-term treatment with non-selective beta blockers, it decreased clinical decompensation, a liver-related death by half. This was mainly due to decreased rates of ascites. This was mainly because of due to decreased rates of ascites, which is the most common decompensation event, and for which there were previously no effective preventive drug therapy. We used to use the beta blockers for prevention of the primary prophylaxis, secondary prophylaxis of the variceal bleeding, esophageal variceal bleeding, as well as for the portal hypertensive gastropathy. But mostly we were using it for the primary and secondary prophylaxis of the variceal bleeding. This is a study which told that no, it can be used as a prophylaxis of development of ascites as well, which I told you that developing an ascites, if a patient develops ascites, either the patient is in stage 1 of the compensated cirrhosis or stage 2 of the compensated cirrhosis, the patient jumps to the decompensated cirrhosis. And I told you this as well, that when we presented our data of 2,780 patients, the complications profile at presentation of cirrhotic patients at our center, and we found that ascites was the most common decompensatory event, 44%. So in our clinical practice, this is the ascites which makes a patient decompensated, If somebody says HE, if HE happens in the compensated cirrhosis or in the non-cirrhotic patient, this is a result of acute and chronic liver failure. Or in the decompensated, already patient has got ascites. So this is the ascites mainly, which is the most common decompensatory event in cirrhotic patients, followed by the variceal bleeding. So the 1/3 of the patients in the trial received carvedilol, and 2/3 patients they received propranolol. Their doses were adjusted based on the heart rate and blood pressure. And patients who received carvedilol had a greater portal pressure reducing effect and had better outcome. And this is the entire study cohort. And what this showed that ascites was 14%, the cumulative incidence of first decompensating event developing during follow-up in the overall series of patients treated with beta blockers. It was the 14% decrease in the ascites. This is the great effect. The decompensated compensation by the death, the cumulative incidence of decompensation or death significantly was lower in the non-selective beta blocker group. And 2/3 of the patients with development of high-risk varices had ligation in a post-hoc analysis, including beta blockers. Patients in the non-selective beta blocker maintained greater benefit. And the benefit of non-selective beta blocker was more pronounced in patients with small varices and non-alcoholic cirrhosis. So in the hemodynamic impact, the average duration of hepatic venous pressure gradient was 11%. And this is the cumulative incidence of developing decompensation and death. And they were significantly lower in patients with decrease in hepatic venous pressure gradient of more than 10% from the baseline. So the beta blocker, they had a positive impact in reducing the first decompensatory event, that is the ascites, as well as in decreasing the variceal bleeding. Though and the adverse events, the similar rates in both groups, the placebo and in the beta blocker groups, and non-major adverse events were fatal in any of these patients. So the authors conclude that the long-term treatment with beta blockers can increase decompensation-free survival in patients with compensated cirrhosis and clinically significant portal hypertension, mainly by reducing the incidence of ascites. And this is the non-selective beta blockers adverse effects. I don't need to go into the detail, but yes, there are contraindication, like absolute contraindication, like second or third degree AV blocks, or asthma, or cardiogenic shock, or cocaine-induced coronary angiography, or known hypertension to related contraindication like uncontrolled diabetes or Raynaud phenomena, or you will decrease the dose if the patient develops hypotension and there is acute kidney injury. Are commonly reported side effects are the weakness and shortness of breath and all those things. This is, of course, the clinical decision. When you start these patients on the beta blockers, you need to take these aspects into account. So, dear colleagues, to sum up, this is the compensated cirrhotic patients when they are asymptomatic and they deserve the longer survival. And this is over the time when they decompensate, they develop variceal bleeding, ascites, or hepatic encephalopathy, and they have got the impaired short-term survival. The first decompensation is the ascites or the variceal bleed. When they develop hepatic encephalopathy in the initial stages, this is as a result of acute and chronic liver failure. And once the patient is decompensated, then this is as a result of the hepatic encephalopathy. And the dividing factor is the development of clinical significant portal hypertension, which is the main determinant of decompensation. And this is when the HVPG is more than 10 millimeter of mercury. So the beta blockers, what they do, they lower down the hepatic venous pressure gradient to less than 10 or to 10% to 20% of the baseline, and because of this, they block the decompensation event in these patients. The cirrhotic patients, I always say, they are very delicate creatures. We need to give extra care. We need to take their lives are very precious ones, and we need to make all decisions which can improve their survival. So the take-home points is that after diagnosis of cirrhosis is made, the next step is to determine whether the patient has clinically significant portal hypertension, and if so, to start non-selective beta blockers to prevent decompensation. The non-selective beta blockers prevent decompensation, mainly ascites, in patients with clinically significant portal hypertension. So thank you very much, dear colleagues. I hope that I explained to you the pathophysiology of portal hypertension and the role of the beta blockers. Then the role of beta blockers is not confined only to the prevention of the variceal bleed. It also prevents the decompensation, and the first decompensatory event in this patient is the ascites. So I stop here, and to see you in the next video on the topic. Thank you very much.